We usually think of a doctor's waiting room as the first step toward getting answers, but under the sterile fluorescent lights, surrounded by outdated magazines, it can be one of the most isolating places on Earth. Consider a patient we will call Alex, a fictional composite drawn from a very real, very common pattern. Alex has been diagnosed with post-traumatic stress disorder. They experience the classic symptoms clinicians look for: intrusive flashbacks, acts of hypervigilance, where the brain is constantly scanning for threats. But that diagnosis leaves out massive, heavy pieces of Alex's daily life. It ignores the harsh, unrelenting inner critic. It skips over the severe emotional swings that take hours or days to settle. And it fails to explain a complete inability to feel safe, even in the closest, most loving relationships. When the medical label applied to your file contradicts your actual lived experience, you fall into a dangerous gap between clinical theory and reality. The medical system has a standard vocabulary for patients who do not fit neatly into diagnostic boxes. They are labeled treatment-resistant or described in clinical notes as difficult. This initiates an exhausting cycle. Patients bounce from one therapist to another, trying different medications and different therapies, pouring time and money into a process that never seems to touch the actual wound. After months or years of this treadmill, the patient reaches a devastating, quiet conclusion. They decide that the therapy is fine, the doctors are right, and they themselves are the broken variable. If a patient is trying everything and nothing is working, we have to ask what the medical establishment is missing when those classic trauma frameworks fail. To find the answer, we have to stop looking at the patient as a biological failure. The nervous system in these cases is actually functioning exactly as it was designed to. The condition we are looking at is complex PTSD, or CPTSD. This animated diagram shows classic PTSD. Notice the single, sharp spike representing an acute, isolated traumatic event. Watch how the timeline expands for CPTSD, showing continuous, dense, overlapping spikes. This is prolonged, repeated trauma from childhood neglect, chronic abuse, or inescapable instability. Complex PTSD is a profound, necessary nervous system adaptation. The brain rewired itself to survive an environment where trauma was the daily baseline. Clinicians look for 3 specific symptom clusters to identify CPTSD. This 3-part conceptual diagram maps them out. The first node's erratic waves represent severe emotional dysregulation. The second node activates as a shrinking, isolated core, representing a deeply embedded negative self-concept and pervasive shame. Finally, the third node's fragmented lines map to persistent difficulty trusting others and maintaining safe relationships. Because these 3 clusters manifest as behavioral and relationship issues, clinicians frequently fall into a specific trap. They misdiagnose CPTSD as a personality disorder. When a clinician treats an adaptation to trauma as an innate personality flaw, they attack a symptom and ignore the cause. These extreme reactions are outdated survival mechanisms. They kept the person alive in a war zone, and they are simply continuing to fire in peacetime. A formal diagnosis of CPTSD can only be made by a licensed clinician, and treatment outcomes will always vary from person to person. But once properly identified, the therapy requires a completely different architectural approach. Standard rapid trauma processing often backfires here in these cases, completely overwhelming a nervous system that is already maxed out. Evidence-based directions include EMDR, trauma-focused cognitive behavioral therapy, and dialectical behavior therapy skills. The strict rule across all of these is that safety, stabilization, and distress tolerance must be built first. When treating prolonged trauma, the slow pacing of the sessions and the earned safety of the therapeutic relationship hold just as much weight as the clinical methods themselves. Finding a provider who understands this pacing is crucial for patients exhausted by the system. Coping and Healing Counseling, or CHC, was built for exactly this reality, employing a culturally competent team of over 15 licensed therapists serving Georgia. They remove the standard barriers to access by operating a 100% HIPAA-compliant telehealth practice, available across all 159 Georgia counties. They accept Medicaid at a $0 copay, and most commercial plans range from $10 to $40 per session. A nervous system that brilliantly adapted to survive a painful past can, with the right team and the right pace, adapt to thrive in the present.